अरे आपको उनको बुलाना जरा
कौन सी
जो भी गए हैं।
बालमुड़ी
हाँ
हेलो
सुबह मेरे somebody has taken my blood. I want to know the report.
Okay, sir. I'll ask him, sir.
Ma'am, you can start the session.
Okay. Opened up.
Yes, ma'am.
ब्लड दिया था उसकी रिपोर्ट मिल गई।
So, very good evening to everyone. And continuing with our sessions, monthly academic sessions of MAPMR. This is our 11th session, and we are very happy to have with us the Dean of PMR, Professor Srivastava sir. And I would like to uh, invite Dr. Abhishek Srivastava, who is the president of MAPMR, to introduce ourselves.
Good evening, friends, respected sir. Today is a great day for MAPPMR that our grandfather of or father of or doyen of PMR in India, Professor R.K. is today with us. He needs no formal introduction, but as customary, he is ex-DGHS and Chairman Medical Council of India, DG to ICMR, Senior Policy Analyst to the Wish Foundation. He is teacher to all of us for the Satyajang Hospital, then moved to DGHS, and did a lot of work in PMNR and CBR. He has been awarded many awards, including the BNCNA Gold Medal. It's our privilege today to hear Professor R.K. Srivastava, sir. Welcome, sir.
Thank you, Abhishek. Thank you, Namita. Can I have my PPT?
Asmita, please share.
Now today I am here before you, and I would like to talk on little bit different subject, not the routine type of subject which in this webinar we talk about clinical problems, their solutions. I will talk about certain type of things which are futuristic to the PMR, and I will try to blend it with the mission mode program of Viksit Bharat, and I will try to suggest a new strategy which is blended PMR delivery strategy so that we can move together towards better tomorrow. So my theme is like this. It's not moving. Okay. Now you know what is the vision of Viksit Bharat. The vision is to transform the country into a self-reliant and prosperous economy by 2047, which is the 100th year for the independence. And that is through the economic growth, technological upgradation, infrastructure development, social empowerment, sustainability. And in social empowerment, health has got a clear focus. Now, the focused population on which this Viksit Bharat is making an endeavor to become a Viksit country by 2047, this population is youth, poor, women, and farmer. These are the thrust group which will lead to a Viksit Bharat. And in our association, in our PMR, these are the groups which will take us to the Viksit PMR through the new strategy. Now, the theme of Viksit Bharat is very simple. The India should become a self-reliant, high-income country. That means, if you talk about health, access to the high quality, affordable, and comprehensive health care, besides many other things like zero poverty, creating a food basket for the world, so on and so forth. Now, if we look at the theme blended with the PMR, then we can very well say that the theme for Viksit Bharat, if we talk about the PMR, is from the first step to the golden year. That is advancing rehabilitation across the whole lifespan from womb to tomb approach. And there we link PMR to Viksit Bharat, a mission mode program which is undertaken by the PSA in Prime Minister Office, who connect all the ministry including the health ministry to plan and strategize for it, where health, wellness and social prosperity is the task of health ministry, and it is one of the 10 pillars of the program. And the remaining pillars, which are 9 in number, which are like convergence reform, technological reforms, innovation reforms, infrastructure reform, education and workforce skilling reforms, and diplomacy reform, all 7 in number, they are overlapping to the health and wellness, and so to the PMR services into the Viksit Bharat mission. And every program will become successful if there is any backup money. We know that the GDP of India at present is 2,700, but today the GDP of China is 13,121. If we want to be Viksit by 2047, at least if we want to equal to China, we should have a GDP of China what it is today, added with it the inflation. So that is the PMR link to the Viksit Bharat, and that requires definitely a new strategy,
വേണ്ട
what I call a blended
ഇത് എടുത്തിട്ട് അത് വേണ്ട
healthcare strategy.
അത് എടുത്തുക്കോங்க മാഡം അത് വൈറ്റ് ആൻഡ് റെഡ്
Now, component of the health pillar, that is pillar number 6 in the Viksit Bharat, particularly the digital system, is a digital health ecosystem, public health infrastructure strengthening, holistic well-being through Ayurveda, and a good type of healthcare diplomacy. These are the 4 components of Viksit Bharat which moves it towards the self-reliant healthcare for all. Key component and the areas which are there in the digital system, which is the first portion, is universal digital access, digital literacy initiative, e-governance and public service delivery, education technology, that is EdTech integration, creation of innovation hubs and startup ecosystem, and data analytic and AI application. All these are in place as on today in this country. Now, these achievements are through a model of which is known as STRIDE model. S stands for startup. It means it supports startup growth and drive economic progress and job creation. That is Vikas. T stands for technology and innovation, that is, focus on AI and emerging technology to improve efficiency and output. R stands for research and development, which foster real innovations and leading to strengthening of scientific and technological capabilities. I stand for infrastructure, which build world-class infrastructural support to enable sustainable growth and better quality of life. D for deployment and adoption to implement advanced solutions so that widespread adoption across the sectors of the solution is ensured. And E is enhancing skilling and capacities. Equip workforce with future ready skills and enable adaptability in evolving job market. So this stride strategy or model is applicable to the PMR for Viksit Bharat as well. The strategy which I said is blended healthcare strategy, and when it relates to PMR, the blended PMR healthcare strategy. It is based on the principle of moving together through blended healthcare, and the thrust is on EPSR. EPSR stands for Embedded Health Policy System Research Strategy. It is a WHO strategy for bettering the life of beneficiaries by universal PMR care and within the framework and timeline of Viksit Bharat, that is by 2047. Now, two words about the EHPSR. Some of you might have heard about it, others might not have heard about it. In simple words, it is local research in local health facility by local researchers either placed within the system or hired from outside, which use the local data, apply local analytic and evidences, and create local solution so that the system in that health facility is improved. So it is all local for improving the local health system. This is in brief the embedded health policy system research, and it is recommended by WHO. It has been accepted by the health ministry and is being implemented through National Health Mission. Now, why PMR should be considered in the center today? What is so special about it? PMR is only 100% exclusive rehabilitation specialty. PMR specialist is the only person trained holistically for service provision from acute to chronic stage, from primary to tertiary care, from preventive to rehabilitative services. PMR specialists possess soft skill to deal with disabled, elderly, crippled from ICU to home care. And surprisingly, in spite of being the fourth pillar of the healthcare, there is no national rehabilitation program under Ministry of Health and Family Welfare even today. Therefore, only PMR specialists can strategize, plan, organize, implement, and monitor such type of national program. PMR specialists constitute one of the HHR, Health Human Resource for Rehabilitation Services. If you look at the health human resource for the rehabilitation services, we can classify it into health professionals and allied health professionals. Health professionals are usually led by PMR specialists, but at many places PMR specialists work as a partner role, supported by different type of specialists like pediatrician, orthopedician, neurologist, cardiologist, intensivist, and support system is provided by physiotherapist, occupational therapist, speech therapist, orthotist, and prosthetist. They are all health professionals which are there to take care of the total rehabilitation service and care delivery. Now there is second group which is known as allied health professional group. There are 10 recognized groups and the commission which is known as National Commission has recently been constituted and its ruling has started from 2025 only. But it is important for us because there are good number of allied health professionals. Without these health professionals, it will be very difficult to constitute a multidisciplinary team and take care of holistic rehabilitation care delivery. They are physician associate, physiotherapy professional, nutrition science professional, ophthalmic science professional, and occupational therapy professionals, behavioral science professionals, and health information and management informatic professional relevant today because of digital health and digital health delivery in rehab. Now let us talk about the regulatory framework. In India, there are standard regulatory systems which are existing from the time the health system evolved in the country. NMC for medical regulation, undergraduate and postgraduate both, National Board for the postgraduate regulations, RPWD for regulating the person with disability, RCI Act for rehabilitation, education, regulation, National Trust for CPMR autism and multiple disability, National Commission for all these allied health professional, DPDP it means Digital Data Protection Act, which will protect the data so generated by the digital system and telemedicine as on today. Now I will talk separately about each of these regulatory systems. NMC created a competency based undergraduate curriculum where PMR is included with definite number of hours for teaching and training, and also there is an optional internship training provision kept over there. It was notified once as an essential specialty, but later on it was denotified, reasons unknown, and at present it is working as a desirable specialty. If anybody wants to run a medical college, it is a desirable specialty, it is not mandatory. That is the factual status of NMC as on today. National Board of Examination from the very beginning is having PMR as a core subject under the surgical specialty group. There is a separate committee for it, and it created first competency based curriculum for postgraduate teaching in PMR in 2014 and runs fellowship program as a subspecialty training program like pain subspecialty, geriatric and pediatric rehabilitation. Then there are other cutting across regulations like RPWD Act, RCI Act, National Trust and NCAP, which are governed by other ministries. Now National Health Policy. From the regulation, let us come to the policy. The policy document was circulated in 2016. It has two chapters. First was dealing with the situational analysis in 2016 and before, and second was dealing with the prospective recommendation so that the future of the healthcare can be planned. It gave directions for development of healthcare in India. The directions were based on four major principles. First was general principle, second was principle of health for development, third was growth oriented healthcare, and fourth was technological integration. All the policy directions which were general in principles are operating through influencing, enabling and buying services. Influencing operation of the healthcare system, enabling private sector to strengthen public sector, and buying services from the private sector strategically. This is going to facilitate overall growth of the health sector, and it has also clarified that because the major chunk user of the money is spread over in the primary healthcare system, So two-thirds of the money should be spent over the primary healthcare system. The policy direction number 2 is health should be taken up not as a care without a focus on development. Health should be taken up as health care for development. Development means overall country development and economic development. It set direction for development agenda through health by partnership between public and private sector by bridging public health gaps and organizing strategic purchase of services from the private sector. For that, it decided to increase the public health spending from 1.15 to 2% of the GDP gradually. So that was the recommendation and direction of NHP 16 number 2. And this could only be achieved by following a WHO recommended health cube which is having three arms, and verb arm deal with the service, other with the population coverage, and third with the money. Indian system is deficient in all these three arms, and PMR services and PMR care is deficient much more in all these three arms. It means that the coverage is poor, the population is less covered, and the money provided for it is much less. So that is where the focus will be in future for the strategy. Now, the policy direction clearly spell about that healthcare should be growth oriented healthcare. If we invest 100 rupees in healthcare, we should create a healthier population which can give back return of 150 or 200 rupees. That is what is growth oriented healthcare. High health inequities are undesirable for India. Being fifth largest economy with sophisticated knowledge, technology and intervention, it needs definitely a new strategy to deliver health care which is growth oriented. We are having a burden of 28% of communicable disease, 60% of non-communicable disease and 12% of injuries. Need of the PMR services for management of consequences of these diseases is very, very clearly established because none of them are existing today. So the need which is emerging out gradually from this policy is to do the joint treatment planning, cutting across the various specialties which are operating in primary, secondary and tertiary health care, so that we minimize the catastrophic expenses and out-of-pocket expenses. It has been established clearly by the evidences in the policy that absence of joint treatment planning compromises best health outcome, resulting in high inequities in health outcome and less GDP growth. But if it is present within the health system, then this joint treatment planning shall ensure best health outcome resulting in reduction of the catastrophic health expenses and out-of-pocket expenses and thus bettering the GDP growth. So it is growth-oriented healthcare, 100 rupees invested in health, creating a healthy human capital which give a return of 200 rupees. Let us talk a little bit about Ayushman Bharat Digital Mission which was launched in 2021. It is a final mission mode program in operation under National Health Authority. National Health Authority is a separate body created by under the Health Ministry, which has passed through National Digital Health Blueprint, National Digital Health Mission, then pilot, and thereafter the final ABDM was launched in 2021. Till date, that is in 2026, it has created a unique number which is known as ABHA, telemedicine platform, eSanjeevani, EHR, it is electronic health record, HPR, it is health provider registry, HFR, it is health facility registry, e-pharmacy, digital health stock, which is a technology driven ecosystem of ABDM, a sandbox where new innovation can be put in, center of excellence 3 in number, and microsite which is about 600 plus in number. So this is ABDM version 2 today, and it is all operating pan-India under National Health Authority. There is a payer system which is developed in the Ministry of Health, which is known as Public Health Payer System, or more commonly called as Pradhan Mantri Jan Arogya Yojana, a flagship program providing 5 lakh per family per year cover to 10.74 crore poor vulnerable families, approximately about 50 crores, and from 2024 added 70-year and above population to it. Now, what is the situation today as far as the PMR departments are concerned? Most of the medical college have not yet opened PMR department. PMR is absent summarily in 12 states and it 428 medical colleges, that is as per MCI report 2017. 27 PMR departments are operating in 23 states and union territory. Much more has been added on account of opening of new AIMS-like institute, and after the NMC has issued guidance document for making it mandatory once for opening of the PMR department. But association does not have a live register, present registered number in the association about 850 PMR specialists in the country. PG production is both through the MCI recognized courses and the DNB courses. So PG training is in 12 AIMS-like institutions, 3 Center of Excellence, 49 medical colleges and 2 DNB institutions. And total annual production of the postgraduate per year is less than 100, of which about 65 to 70 pass out and rest are either living in between or failing or not continuing the course. The other professional situation, if you look at the professionals which are other than the medical PMR professionals but which are important for the multidisciplinary, is that the focus of the allied health profession, which is important, is on physiotherapy and occupational therapy. Focus of RCI is only speech therapy, audiologist, POE and clinical psychologist, and they are all short against the demand which the country poses today before us to render PMR services all over the country. And as far as the research in this sector is concerned, it is also in a primitive stage, but we can say that ICMR is taking a lead and is created a DART, which is Disability, AT and Rehabilitation Unit under the NCK division. DART has become a World Health Organization collaborating center for Southeast Asia. It has prepared a list of assistive products which are essential, prioritized them, created 5 center and five regional center under one national center which is known as NCAT, and created a tech pod in AMTZ Vizag for innovation translation. There is a funding for the research proposal which is available, and there are 3 types of grant: less than 2 crores, less than 5 crore and less than 15 crores. The standard of service in the public health system is also released in 2023, which is known as Indian Public Health Standard. This provides for PMR services at all the 3 tiers of the healthcare delivery. Their standards are well defined as far as the space, HR, equipments and consumable are concerned. And for primary healthcare, it has recommended a hybrid mode of service, digital plus physical services. But all this is only desirable. None of them is mandatory. So it depends upon the state government whether they want to go for it or not want to go. As far as the association is concerned, we are a professional body of 850 registered members. We have continuously grown, and our focus as on today is for academy development, training, CME, masterclass, research, assistive technology, partnership with government, insurance and sports activities, and partnership with other associations. Demand and supply status today is there is a big gap as far as the service, research, and teaching faculty is concerned. Then demand has further been augmented due to activism, court orders, and the various type of laws. Whatever updated action has been taken has not been able to give desired result till now. MCI and B in central scheme of the PMR and medical colleges have yet failed to give the desired result. The net result is PMR service is invisible in the public health system even after the clear-cut policy and Indian public health standards. Various paramedical service providers mushroomed as an independent service provider in between, and PMR department started working in silos only in the tertiary healthcare, losing visibility and recognition and growth. Now we have got a jumping pad today in form of Viksit Bharat, LMC, National Health Mission with its comprehensive primary health care and urban health care package, ABDM PMJY, which can provide us a platform through which we can move forward for Viksit Bharat so as to render PMR services to all beneficiaries in India based on four strong pillars of robust infrastructure, adequate HHR, a good allocative efficiency and accountable spending of the money, and appropriate technological integration. Unfortunately, today in 2026, we are falling short in all these four essential pillars because we don't have a strategic policy for that. Moving together is very simple. We have to move together with other medical disciplines. We can't work in silos. We have to work with technology and AI. We have to operate with health professionals, with other associations and research bodies. That is the only way for blended healthcare through partnership. Now, what is blended healthcare? What is blended PMR care? A little bit talk about that. How it is, what is its demand, and how it is going to be seen in future, and how what we should do today for it. Now, blended means partnership between public and private sector. If we talk about PMR, the physiatrist is to initiate this partnership with other specialties and super specialties. The head of the institution need to facilitate it. Professional institute need to build partnership with other professional association. IAPMR to develop standard treatment guide and joint treatment plan. NMFs, which is the National Academy of Medical Science, to facilitate it at different association level. And National Health Mission has to direct that the joint treatment protocols and planning need to be introduced within the healthcare delivery, and state health mission director need to execute it within the public health system. So that is how the demand side is there and how it can help in fulfilling the demand through the new strategy. We expect definitely a good outcome if we follow this strategy of demand and supply. We have to partner with all the providers. So at the end of the day, if PMR is able to partner with all those which we have talked about, and this partnership through a doable framework which both of the partner accept and see that this can work. And if we are able to document evidence-based smart health outcome, everything is possible and PMR can reach to the last mile person. I give you some case study of partnership at individual and association level. ICMR, INFR and PMR MOU recently has been signed, a good example of partnership. IFNR and PMR MOU has been signed, it is another example. IAPMR engaged with Niti Aayog for creating benefit packages for inclusion of certain type of rehabilitation services in the PMJAY. IAPMR engaged with National Medical Commission for creating mandatory provision of PMR service for opening a medical college. IAPMR engaged with National Board of Examination in drafting the curriculum for postgraduate medical education, which was based on competency. PMR specialists in personal capacity like me and many more are working for AI and AI powered solutions in delivering the healthcare services for the beneficiary of PMR care. PMR specialists operated in critical care both in South as well as in Uttar Pradesh. PMR specialty during the COVID period used telehealth for respiratory rehabilitation for post-COVID lung health. PMR in teaching and training associated with Neurology Association for stroke rehabilitation. So these are the some actual practice of the partnership which can be seen they are operative, they are doing good. Now there are many things which we have to take up forward as the PMR professional. And this is where I would like to address to our friends who are postgraduates, who are senior residents, who are young faculty, who are senior faculty as well as specialists, who are HODs, who are chairmen of different committee, who are occupying medical superintendent positions or who are occupying the highest position in the government. So to begin with, I will talk about the PG, and there are 5 levels of product which this strategy need to develop so that it moves seamlessly forward. The blended PMR healthcare strategy for future. As a PG, you work for joint treatment protocol development and implement and create evidences for better outcome. What you gain out of it? Basic draft of joint treatment protocol. You cultivate researchers' skill. You select and propose thesis topic where your co-guide should be from other specialty. Your joint treatment protocol will form the basis for it, and your benefit is you will be able to publish a research paper. Now all these things will lead you to step 1 of blended healthcare delivery. So what we say that we catch PMR specialist young, transform their mind to adopt this particular strategy, and that will be your contribution towards implementing this strategy. Then we go to the senior resident. Now you are covering OPD, IPD and intervention with a team. You are postgraduate, qualified. You have got responsibility for expansion, refinement of joint treatment protocol, induction of new protocols, evidence creation for better outcome, and facilitating paper, thesis and publication. You can initiate as a senior resident multi-specialty discussion platform on social media or otherwise at other places. General club, you can organize, create new research proposals for grant, and multi-specialty CME and conferences you can very well organize. You as a senior assistant will do your job for the blended PMR care as step 2. Your product is you will have a better claim for induction and selection as a faculty position or as a specialist, and you can become a specialist or teacher and take it up as a career. Now, when you become a junior teaching faculty or a specialist, then your responsibilities and your role is further modified. Now you can plan for your role for longer duration and larger vision. You need to support your PG senior resident for expansion of joint treatment protocols. You have to give your annual appraisal report. In that annual appraisal report, you can create a separate area for implementation of blended care strategy, and whatever you are trying to achieve through it, you can document it. And this is a systematic involvement of strategy implementation through performing as a junior teaching faculty. This is the third step of action. What you will get a better worth creation of PMR in the institution, improved reporting material in your CR. And remember that when your CR you report in this fashion, you will get a review of very good or outstanding. But later on, when you become a professor or you occupy a chair of head of department, your responsibilities are further enhanced. Now you are an influencer and leader. Some may become MS. Your job is to promote blended care strategy both for staff below and specialty below you and for the government and administrator above you. Create annual operational plan and put joint treatment protocol as priority component and materialize fund for it. Without money, nothing moves. You are in a position you can demand and or you can provide the fund. So work for it. You must form a standing committee for augmenting this new strategy implementation. You ensure that the principal or medical superintendent issue internal orders that the joint treatment protocol should be followed by all specialties in partnership with the PMR department. It will be the fourth step of implementing the strategy. By product prototype documentation of institutional framework of multi-specialty system, you will make it happen. STG and SOP for practice of this strategy can be created by you. Advocacy and promotion evidences for the PMR will be able to showcase with the other faculties for better health outcomes. As a professional body at national and state level, you can create micro plan for competency based medical curriculum. Your regulator created macro plan. Now at simple level, say for institution of running a pain clinic, you can create a micro plan with all the micro nut and bolts in place and put it up as an appendix in the medical education system of PMR. You can do evidence sharing strategy for promotion of PMR care strategy. You can create standard treatment guideline, SOP, joint treatment protocols in primary care for facilitating integration of PMR for better health outcome. You can take up marketing of PMR services in the private sector and quote its cost effectiveness as has been done in past by neurorehabilitation or in the hyperacute rehabilitation in ICUs by other organizations. Share evidences of good use of the money, smart money use, that is allocative efficiency, accountable spending by including PMR services as essential department to the NMC, which will take it up again and recommend for making it mandatory. Create a state level steering committee, arm length body away from government for inclusion of PMR and in NHM and medical education. Now, your micro level competency based medical curriculum will be supported by multi specialty expert committee at hospital and government level. State steering committee can support the PMR expert committee to analyze evidences. So all these things can be done by association and the professional bodies. Now PMR association can do today It can create PMR need to facilitate partnership with other associations at national and state level and hold joint conferences and CME. Neuro rehabilitation is doing it, ICU rehabilitation is doing it, interventionist is doing it, cardiac rehabilitation professionals are doing it. So all these things are already happening. You can expand it. IAPMR need to engage with NEMS for multi-specialty partnership and issuance of executive direction to institutions and medical college and hospitals and direct principal and medical superintendent for internal order for interdepartmental convergence. This happens more easily if IAPMR is involved in it. IAPMR need to facilitate issuance of executive direction from NHM to the state NHM for inclusion of joint treatment protocol. A state PMR association should facilitate the same type of thing with all medical college and NHM in states, and all state PMR bodies should ensure participation in the PIPs when funding is being provided for implementation of joint treatment protocol. And this is the full and final step of the new strategy. That is how, starting from a PG up to the level of the professional body, we can enter into the health delivery system which is operating through NHM and where funding is ensured through the PIP. That is all I want to talk to you. In summary, I would like to say that Viksit Bharat is not outside PMR. Viksit Bharat is very well inclusive of the PMR. Let us try to look through the wider lens, through the bigger vision, and try to make PMR service available for everybody. And thank you very much. If there are some questions, I am open for that.
हमारी भाभी का फोन आ रहा है.
Thank you so much, sir, for a very insightful talk. And the Viksit Bharat, I think so, it is an
हमारी भाभी
inclusion
का फोन आ रहा.
of PMR.
Namita, your voice is not coming.
Navita, you are muted.
Oh, she must have muted everyone. So thank you so much for an insightful talk, sir. And the Viksit Bharat is inclusive, very well said, as you have said that inclusive Bharat is inclusive of PMR, and showing us the path of each and everyone, because telling us that yes, charity begins at home. So it is the onus of each and every PMR physician to do their own part. That is what is the message, and it is very well taken. Thank you so much. And telling each and every, from right from the resident, PG resident to the professor, what can be done, and also the IAPMR, what can be done for visibility and for inclusion of PMR into Viksit Bharat. Thank you so much, and we will take the comments and the questions. I will just check if there's anything in the chat box. Yadav sir has congratulated you, sir, saying that respected sir, congratulations. Sir, you are there. If you are there, you can you can put in a comment, sir. Yadav sir. Anyway, sir, I would read on behalf of him.
I think Shivlal Yadav has put up a comment. Thank
That's
you,
what, sir.
Shivlal, for your comments. I appreciate you being there, such a senior person, hearing to what I have said. You are
Even
most important research for us. Thank you, Ajay.
Dr. Rajendra Sharma sir is also there, and I would request him to, if he can unmute and if any comments, if anything, sir, Rajendra Sharma sir.
No comment is very good comment.
Sir, in the meantime, I will take some questions. A lot of focus now on WHO has launched a World Rehab Alliance. And
WHO?
has launched a World Rehab Alliance, WRA.
WRA.
Yes.
And just like we had Health for All 2000, now we have new goal of Rehab for All 2030.
Yes.
Government of India is also a signatory to WHO. I was there in Geneva a couple of years back when it was launched. So as such, Government of India has signed or a signatory to the definition of rehab for 2030. But looking into the current scenario, how can we achieve that goal, sir?
Okay. There are certain milestone achievements which has been made in India. I would just like to share with you. First achievement is the GATE report, which has been created for assistive technology, has been universally accepted. Number two is that Rehabilitation 2030 document has been subjected to an action plan development in the Ministry of Health and Family Welfare, which is being coordinated and modulated through the CHEB under DGHS. Third thing, a WHO collaborative center has been established, which is not only for assistive technology, although it is launched in the unit of the assistive technology, it is for 2020-30 rehabilitation action plan. And recently, I think about a month back, the award has come. It is connecting all the Southeast 10 countries of the Southeast Asia, and it has got a focus on assistive technology, but it has got coverage of all the type of provisions which are made for rendering the rehab care services. Now, moreover, if we try to dissociate the demarcation between the ICMR and Ministry of Health, at one time Ministry of Health and Family Welfare and DGHS were occupying the dominant position in service delivery. Today it is a little bit different. DGHS is at a lower scale and ICMR it is a higher scale. So ICMR is leading all these things, and if there is a collaboration of ICMR, which is with NCAT, it means National Center, with 5 regional centers, with clinical validation lab, it is all for improving the rehabilitation care. Now coming back to your basic question, is it possible by 2030 that we should be able to go to the last mile person for giving the rehabilitation care services? I have got an answer which is plus and minus both. The plus, because if we use the technology which is available with you, it is possible. Why it is possible? If bank can reach, if mobile can reach, if optical fiber can reach up to the last village, if towers are being expanded, internet connectivity is being improved, then why not in the healthcare sector? That is one strongest. But all depends upon how best we use the technology for primary health care if you want to reach to the last mile person. And no, because in reality we know that all these laws, all these acts are conflicting with each other. Like in DPDP, it says that the custodian of the act, custodian of the data is the patient, and he has got the right to erase. And in NMC it says that you have to maintain the data for 3 to 5 years. So these conflicts which are there in various acts, so are there with other acts also. Like you know about the National Commission, there are conflicting things in it. So all these things, if government can address these things at the top level and use technology at the best way, then this may be possible because 2030 still has got 4 years to go. And our telephone penetration and banking penetration has happened hardly in 3 or 4 years. So Possibilities are there, but I don't know. That's why I said yes or no both.
Thank you, sir. Thank you. So you answered my next question also was that how can we reach the primary care? And you have shown in your slide that the hybrid model is the what government is proposing, and with the penetration of our cell phone, we can reach the primary care model also.
I tell you, if you look at the IPHS document is Indian Public Health Standard document. It was created in 2023 or 2019, somewhere at that time. I don't remember exactly. But when this document was being created in NHSRC, the Himanshu name boy was there. He worked under me. I told him, let me write the PMR services portion. I wrote it. And that is where I suggested for the three type of primary health center, three type of system which exist. One was hybrid system. I wrote mandatory, they converted it to desirable. That is all. But still, from nothing, something is there. Which states, like South states, they can use it.
Yes.
So it all depends, boils down to money. If you adopt a growth oriented healthcare, then the money also comes. It is human capital, healthy human capital development. And healthy human capital development cannot exclude the clientage of PMR specialist, because this clientage take care of about 50% of burden of the disease, NCDs, elderly population and disabled,
Mm.
including children. So this is a huge population. They can't ignore it.
Sir, my last question is regarding the Ayushman Bharat scheme. So what is the penetration of rehab services in Ayushman Bharat schemes?
6 packages are there. Out of 200 plus packages, 6 packages are there. They are for spinal cord injury, hemiplegia, amputation, and 3 packages more.
Okay.
And these packages are reimbursable. In private insurance system, Star Health Insurance System is providing comprehensive health care but at a top-up class. CGHS, ECHS, both are having prosthetic and orthotic system and cochlear implant included within it. So it is piecemeal. That is not a solution. Solution is everything and anything available anywhere should be made available within the system in a smart way. Without this, last mile care is not possible.
Thank you, sir. Thank you. Navita.
Thank you so much. Thank you, sir, for enlightening us. And we have already finished 1 hour. And before it automatically goes off, I would like to invite our secretary, Dr. Amit Mamre, to say a few words before we close.
हल्का कर दो यार, बहुत ठंडा लग रहा है.
Yes.
Amit, I think so, Amit, there might be some connectivity issues because in AI, PMR
So
always.
you say thank you.
So I will say thank you, sir. Thank you so much, sir, for a very wonderful talk. It was very eye-opening for us. I think so. The awareness will be more amongst even all of us as PMR physicians, the young ones and the senior. I can see the senior faculty also sitting throughout the one hour, and that's commendable. The next time we are coming back in next month of June, and I would like to ask everyone, all the young physiatrists, what do you want from us? If you give us within, say, the next 10 days, we will think about it because we have to invite the faculty also, and you can DM me, and if not, then we'll come up with the best one. So thank you so much. With this, we end the session, and I would like to again put my thanks to Sir Shivastav sir. Both the Shivastavs are there. So thank you, Dr. Abhishek, and thank you, Shivastav sir, and thank you all the delegates and the participants who were there for their patient listening. And I'm sure everyone will be going enlightened with this talk. Thank you so much, sir.
Thank you. It was my pleasure to be there. Thank you very much, Amita. Thank you, Abhishek. Thank you, everybody who has participated and listened to me. Thank you.
Thank
Thank
you.
you, sir. Thank you.